Welcome back to Neurovascular Nuggets, everyone. Prof. Mansur here, and I'm really excited about today's topic because it delves into something that often gets lumped together, but new research is showing us just how different it can be. Salma, you've been looking into this study, haven't you?
I certainly have, Prof. Mansoor. It's fascinating, really. We often talk about atrial fibrillation or AF as the major risk factor for ischemic stroke, and rightly so. But this particular study, which is the focus of our 12th neurovascular nugget, really makes a strong case for distinguishing how that AF is detected. It's not just AF is AF anymore, apparently.
Exactly, and that's such a crucial point because in our clinical practice, we're constantly trying to refine our risk stratification and treatment strategies. If we can get more granular, we can provide better, more personalized care. So, for our listeners who might be familiar with the basics, what was the core question this study set out to answer?
The study compared the risk of recurrent stroke and overall outcomes between patients whose AF was detected via a standard ECG, the immediate, often in clinic test, versus those whose AF was found through prolonged cardiac monitoring or PCM. This could be anything from a Holter monitor to an implantable loop recorder, monitoring for days or even weeks after an initial ischemic stroke or TIA.
Right, so a snapshot versus a longer movie, essentially. And the findings were pretty striking, wouldn't you say? Because intuitively you might think AF is AF, regardless of detection method, but the data tells a very different story.
They are, they were absolutely striking, Prof. The big headline, and it's a significant one, is that ECG detected AF was associated with a five-fold higher risk of recurrent ischemic stroke compared to PCM detected AF. And this wasn't just a raw number, it held true even after adjusting for factors like anticoagulation use and other common confounders.
Fivefold, that's not a small difference. That really challenges the idea that all AF carries the same stroke risk. It suggests there's something fundamentally different about the patient populations or the nature of their AF depending on how it's initially picked up. What did the study reveal about why this might be the case?
Well, they looked at various patient characteristics and it became clearer. Patients with PCM detected AF tended to have lower cardiovascular risk profiles overall. They had better cardiac parameters and, as we've noted, significantly lower stroke recurrence rates. It paints a picture of potentially newer, perhaps less established AF.
So, if you pick it up on a standard ECG, it's more likely to be a long standing, perhaps more severe form of AF, suggesting a higher pre existing thrombotic burden. Whereas the PCM group, where you're actively hunting for it over time, might be catching these more paroxysmal, perhaps shorter duration episodes.
Precisely. The study actually quantified the AF burden in the PCM detected cases. The median duration was quite low, around 5 hours, and a burden of about 2.23% over a 14-day monitoring period. So for many of them, it's really quite transient.
That's a very low burden, which reinforces the idea that these are often newly emerging or less frequent episodes. But, and this is important, not all PCM detected AF was low burden, right? There was still a significant subset that showed more extensive AF.
Absolutely. It wasn't uniform. The study found that about 29% of the PCM detected cases actually had higher burden AF, meaning episodes lasting longer than 24 hours. So while the median was low, there's still a significant proportion where the AF is more substantial, even if it took longer monitoring to catch.
That's key. It means even with PCM, we're not just dealing with fleeting, clinically insignificant episodes. Some of these are significant, even if they're not immediately obvious. This brings us right into the clinical implications, doesn't it? How should this change how we think about risk stratification?
It definitely should. The study really underscores that there's significant heterogeneity in thromboembolic risk between these two groups. The old thinking that AF is AF and the risk is the same once it's detected really needs to evolve. ECG detected AF shouldn't be considered similar to PCM detected AF. They likely warrant entirely different clinical risk stratification approaches.
So, if a patient comes in with an ischemic stroke and we immediately see AF on their admission ECG, that patient, based on this data, is at a much higher immediate and probably long term risk for another stroke than someone we send home with a monitor and find AF 3 weeks later. That has huge implications for how aggressively we manage them, what discharge planning looks like, and what kind of follow up we initiate.
Precisely. Imagine two patients, both with a first ever ischemic stroke, both newly diagnosed with AF. If one's AF was captured on the initial ECG and the others through a 7-day Holter, their pathways post-discharge might and perhaps should diverge quite a bit in terms of perceived urgency and intensity of management. The ECG-detected patient, for instance, might need a faster track to higher levels of anticoagulation or more intensive monitoring for other factors.
That's a really concrete example, Salma. It's not just an academic distinction, it's about patient lives. And what about the PCM detected group? While their risk is lower than the ECG group, it's still AF and it still carries a stroke risk, right? We wouldn't just ignore it.
Absolutely not. The study makes it clear that PCM detected AF still carries an important stroke recurrence risk that warrants anticoagulation. This is especially true, as we discussed, in those cases where the AF burden is higher, exceeding that 24-hour threshold, for example. We can't become complacent just because it's PCM detected. It's a risk and it needs to be managed.
So the take-home message isn't to deprioritize PCM detected AF, but rather to recognize the spectrum of risk and to prioritize even more aggressively the ECG detected AF. It's about refining our understanding, not dismissing a risk factor. It almost feels like a new subclassification within AF for stroke patients.
Exactly, Prof. The clinical implication here is really about the importance of distinguishing between these AF diagnostic types. It's crucial for both prognosis and for guiding the management of stroke patients with newly diagnosed AF. It's not just about do they have AF, but how was their AF found?
Which begs the question, Salma, how do you see this influencing guideline development? Because current guidelines, while comprehensive, might not explicitly differentiate risk based on this detection method. Do you think we'll start seeing this distinction integrated?
I certainly hope so, Prof. I think this study and similar ones will push for more nuanced recommendations. It's not about throwing out the THA2 DSH for instance, but perhaps adding an additional layer of risk stratification within the AF diagnosis based on how it was detected. Maybe an AF detection modifier could be something for the future. It could influence not just the choice of anticoagulant, but perhaps the intensity of other stroke prevention measures too.
That's a brilliant thought, because if someone's AF is so established that it's picked up immediately on an ECG after a stroke, it suggests a chronic underlying arrhythmic pathology that might come with other, more generalized cardiovascular vulnerabilities that we need to aggressively address. Whereas the PCM group might be experiencing their first major episode, perhaps triggered by an acute event, and may have a slightly different overall risk profile.
And it highlights the value of prolonged cardiac monitoring, doesn't it? Before this kind of research, we knew we should look for AF in stroke patients, but perhaps the full significance of when and how we found it wasn't fully appreciated in terms of prognosis. It validates the effort to do that extended monitoring.
Absolutely. It reinforces the importance of diligent follow-up and monitoring in stroke and TIA patients, especially when the initial ECG is clear. Catching that paroxysmal AF, even if it carries a lower relative risk compared to ECG-detected AF, is still crucial for initiating life-saving anticoagulation. We're talking about preventing future strokes, and every bit of information helps.
It also makes me think about the patient journey. A patient who's just had a stroke is already in a vulnerable state. Knowing this distinction can help us communicate risk more accurately. Instead of just saying you have AF, so you're at risk, we can tailor that explanation. Your AF was detected right away, suggesting it's been present for a while, making your risk slightly higher than someone whose AF we had to search for over weeks. But both types need treatment.
That's excellent, Salma. Patient education and shared decision-making become even more powerful when we have this kind of detailed insight. It allows for a more informed conversation about prognosis and the rationale behind our treatment recommendations. Are there any potential pitfalls or things we should be cautious about when interpreting this, in your opinion?
I think the main thing is not to generalize too much from a single study, even if it's robust. We need more research, perhaps larger prospective studies, to really cement these findings and see how they play out in different populations and healthcare settings. And of course, the technology for PCM is always evolving. So, how does that factor in? A 14-day monitor might catch different things than a 30-day monitor or an implantable device that lasts years.
Good points. The duration and type of PCM will certainly influence detection rates and possibly the burden of AF discovered. But the fundamental distinction, instantaneous detection versus surveillance detection, seems to hold a lot of weight. So in summary, for anyone listening and trying to distill this down to a practical nugget,
In summary, differentiating between ECG detected and PCM detected AF has significant implications for risk stratification and treatment decisions in stroke patients with newly diagnosed AF. It's not just about if they have AF, but how it was found. ECG detected AF means higher risk, but PCM detected AF still needs management.
Perfectly put, Salma. And for anyone wanting to dive deeper into the original article, you can find the link in our show notes and on our Neurovascular Nuggets page. It's a really important piece of research that's going to shape our practice for years to come. Thank you so much for breaking this down for us today, Salma.
My pleasure, Prof. Mansoor. Always great to discuss these vital updates. Thanks for having me.
And to our listeners, thank you for joining us on another episode of Neurovascular Nuggets. Keep learning, keep questioning, and keep striving to provide the best care for your patients. We'll catch you next time.